Great. I'd like to welcome everyone to today's webinar, Lethal Means Safety, Why and How to Have the Conversation. This webinar is sponsored by APA's Division 18, the Veterans Affairs section. And I'm Monica Roy. I'm not Howard Steinberg, as it says by my face here, but I'm Monica Roy, the past chair of the VA section of Division 18 and a psychologist at the Boston VA healthcare system. Before we get started, I'd like to take a brief moment to mention that at Division 18, psychologists in public service have been the home for VA psychologists and other public service psychologists in APA since 1946. If you're interested in learning more about Division 18 and the VA section, please check our webpage in the web links pod on your screen. And one last note before I introduce our presenter, all questions can be entered into the chat box throughout the presentation. We'll try to respond to questions as we go, but we'll also leave plenty of time after for the presenter to answer any questions. And if there are any technical difficulties, please alert me in the chat box and I'll try to take care of them as quickly as possible. Now for introductions, I'm really excited to introduce Dr. Bridget Matarazzo. She is the Associate Director of Clinical Services at the Department of Veterans Affairs, Rocky Mountain Mental Illness Research, Education, and Clinical Center for Suicide Prevention in Aurora, Colorado. She also serves as the co-director of the National VA Suicide Risk Management Consultation Program, as well as the co-director of the Rocky Mountain MIRIC Suicide Prevention Consultation Center service. In her leadership role, she provides consultation to VA providers nationally regarding suicide risk assessment and management, and develops clinical resources, and is a principal and co-investigator.
Thank you so much. And thank you all for calling in today for this talk. I'm really looking forward to talking to you all about lethal means safety and sort of why we need to be having these conversations with some of our veterans and how to do that. As was mentioned, I am the Director of Clinical Services here at the Rocky Mountain MIRIC for suicide prevention. For those of you who might be unfamiliar with MIRICs, there's 10 of them in the country, and ours is focused on suicide prevention. And then I also have an appointment at the University of Colorado. Acknowledgements to a number of colleagues and folks who have just contributed greatly to sort of the emerging field around lethal means safety and have really done some great work that some of what I'll be talking about today is drawn from. So in terms of how this talk is kind of organized, first I'll be talking about the why for lethal means safety. So why do we want to be having conversations about lethal means safety? Then I'll be moving into the who. So who should we have in these conversations with? And then what, and providing some tips and suggestions for both language to use, because I know sometimes if we're learning a new skill like this, it can be helpful to actually see examples of the words to use, but also some strategies and some sort of things to keep in mind as you're having these conversations in a really collaborative way. Okay, so let's jump into the why. So on this slide, you'll see some data that's from the VA National Suicide Data Report. This report is updated regularly every year, typically around the end of summer, early fall. You can always find it online. If you want to Google for the most recent version, you'll find it in there. And you'll see a number of different ways that veteran suicide data is kind of broken up and described in that report. There's a few different points on this slide, but one that I would like to point out is that in 2016, the suicide rate was 1.5 times greater for veterans than non-veterans. And so when we hear that veterans are at increased risk for suicide, that's the kind of data that's being referenced. So when we compare veterans to non-veteran peers, how do the suicide rates look? And they really are higher for our veterans that we are serving. And then if we move into thinking about method of suicide, so how are our veterans dying by suicide? You can see on this table that it's broken out by method on the left, so looking at some of the most common methods. And then you'll see that it shows the percentage of non-veteran adult suicides and how many were due to that method, and then percentage of veteran. and then it breaks it up into male and female. So if we focus on just the columns that are the combined male and female, looking at firearms, if we're looking at the non-veteran population, about half the people who die by suicide, it's due to a firearm injury, whereas in the veteran population, we're looking at close to 70% of the time. So sometimes folks ask the question of why do we focus so heavily on firearm safety in particular when we're talking about lethal means safety, and this is why. We know that firearms are the most lethal method, and particularly among our veterans, the most common way that veterans are killing themselves. And we'll talk a little bit about why we think that is. One thing I want to make sure you all know about is that along with the national data report, there's also these state data sheets. So I have Colorado on here, that's where I live. And you can go online, I have the link on this slide, and you can pull up the state data sheet for the state that you live in, or if you're near a few different states, you can compare. It goes through different rates, and then on the back it does have a breakdown per method. So we do see some variation across the states in terms of method. In states that have more relaxed gun laws, we see higher rates of suicide by firearm, as you would expect, and the reverse is true as well. Those with more conservative gun laws tend to have lower rates of death by suicide due to firearms. So let's talk a little bit about what we know about veterans and firearms. Certainly veterans have a high degree of familiarity with firearms, which is certainly very important to keep in mind when you're serving veterans. They know what they're talking about when it comes to firearms, even if they don't own them themselves. They're well trained in how to use firearms, how to stay safe around firearms, things like that. Veterans are more likely to own firearms than those in the U.S. population. So 1 in 2 own a firearm, and 1 in 3 stores that firearm loaded and unlocked, which is the least safe way to save or store a firearm. So that's important to keep in mind as well, and certainly something you want to be assessing with veterans if they are firearm owning and you're worried about their risk. And certainly, as we already talked about, veterans are more likely to die from a firearm-related suicide than the general population. Okay, so I'm going to talk about a couple different subgroups of interest. One is our female veterans. They're significantly more likely to use a firearm as a means of suicide as compared to non-veteran women. So, for example, in 2016, we saw that around 41% of female veterans died by suicide related to a firearm, as compared to only 32% among female non-veterans. So it is more likely that they will die by suicide due to firearm than non-veterans. 24% of female veterans own a firearm, compared to only 11% or close to 12% for non-veterans. So more likely to own a firearm and more likely to die by suicide due to a firearm. If we think about veterans with PTSD, the research done here was done within the VA, and it was done with some of our PTSD residential programs that we have in VA. About a third of participants endorsed owning a firearm. So, of course, these data may not apply to all veterans with PTSD. As you all likely know, if somebody is getting served in one of our residential units for PTSD treatment, they likely have very intense PTSD. Other treatments often have already been tried, things like that. But for that group of folks at these 2 programs at least, about a third of them did own a firearm. And the study looked at what was associated with firearm ownership and what was not. And I won't read through the full list here, but it is interesting that firearm ownership was associated with lower rates of suicidal ideation, and it was not associated with a prior suicide attempt. So we certainly don't know how generalizable this is, like I said, to other veterans seeking care in our system, and certainly those outside of our system. The firearm ownership being associated with lower rates of suicidal ideation is interesting, and it also not being associated with prior suicide attempt. It's certainly possible that once folks are at the point of being in the residential program and kind of going through a survey like this, they may have already had some lethal means safety counseling if they were at risk and no longer had access to their firearms. So that could be part of the picture there. All right, so let's go back to talking a little bit about the lethality of suicide methods. So again, you'll see here different types of methods over on the left. And so these are for folks who did die by suicide. This is not veteran specific. This includes veterans and non-veterans. And 82% of the time that somebody makes a suicide attempt using a firearm, it results in death. And then you compare that to something like overdosing, and we're looking at 1.5% of the time. So again, thinking about the lethality, when we're talking about making an attempt, if somebody attempts via firearm, it is much more likely to result in their death. Then you can see how these different methods sort of decrease in terms of how often they result in death. So then thinking about firearm access and suicide, there's a group of studies that have kind of looked at this and found that firearm access is in fact an independent risk factor for suicide. So you can be including that sort of in your list of risk factors when you're doing a suicide risk assessment. Firearm ownership rates, independent of underlying rates of suicidal behavior, largely determine variations in suicide mortality across the 50 states. So that's sort of similar to what I was referencing before with the laws, but there could be other things that impact ownership rates, certainly. But if you are owning a firearm, you're more likely certainly to die by suicide. So sometimes when we kind of present that, folks say, well, are firearm owners just more suicidal than non-owners? Maybe it's not about the firearm, but it's about some of these other things. So we'll walk through that and sort of what the evidence tells us. So are people who live in homes with guns more likely to have experienced a mental health problem? The answer is no. Are they more likely to have seriously considered suicide? The answer is also no. And are they more likely to have attempted suicide? The answer is no for that as well. So it's not any of these factors that we might think it is. And it really does seem to be more attributable to the actual owning the firearm. And that's something you'll hear you reference a lot, is that this idea of access, right? If we have quick and easy access to a firearm and it's more likely to result in death, it's going to be more likely somebody would die by suicide if they use it. So another study I wanted to reference briefly, this was done with Army soldiers, and these were Army soldiers who had died by suicide. And they found that the suicide victims were twice as more likely to own a handgun, 4 times more likely to store it loaded, and 3 times more likely to carry it publicly. So again, we'll be going back to this issue of the potential dangerousness of having a loaded firearm. Okay. So that was a lot about firearms, and there's certainly other methods of suicide and suicide attempts that we need to consider and talk about. So some of those are certainly intentional poisoning. We in VA and outside of VA are rightfully so paying a lot of attention to opiate medications and overdose risk there. Many of you may be familiar with the STORM dashboard that helps identify folks that are at risk of overdose, intentional or unintentional. And then there's also some other medications that should be considered that are lethal, and we want to be thinking about when we're talking about lethal means safety with respect to medications. Okay. And then certainly there's other ways that folks die by suicide, and so things like strangulation, cutting with sharp objects, jumping from a height, and suicide on inpatient units, which is relatively infrequent, but does happen. All of these things are worth sort of thinking about when you are working with veterans and doing an assessment in terms of their plans and their access to needs. Okay, so switching a little bit away from methods and talking a little bit about suicidal crises. So suicidal crises typically come on quick. And so our job, and you might sort of be used to thinking about this with respect to safety planning, our job is to help our veterans safely navigate a crisis so that they don't make a decision that they can't take back during that time, specifically trying to kill themselves. So this was some interesting work that was done that found that among folks who had made nearly suicidal or nearly fatal suicide attempts, about half said it took only an hour to go from their decision to attempt suicide and their actual attempt. And then a quarter of them said that it took less than 5 minutes for them to act. So really, really quick from when they decided it was time they were going to make the suicide attempt to when they actually did it. It's a short window of time often. And so we want to make sure that folks are going to be safe in that short window of time, and that there are opportunities for them to change their mind and they don't have quick and easy access to make that suicide attempt. Okay. So question for you all in terms of what proportion of serious attempts do you think eventually, those who make serious attempts, eventually die by suicide? You can just kind of think about what you think the answer is there. So it's actually just 10%. And when I first saw these data, I thought, well, that's fairly low. But if I think about 10 of my patients that I've had that have attempted suicide and one of them is going to die by suicide later, that's still very serious. So we want to be intervening with folks, certainly that have attempted and those who haven't. There's a proportion of folks who die the first time they attempt, a big portion of them. And so we certainly want to be attending to both those who have made attempts and those who have not. Okay, so this might all be sounding well and good, and like we certainly should be having these conversations, and then we certainly want to know if it actually works. And so we don't have a ton of data on the effectiveness of individual-based lethal means safety. For example, in the updated VA/DoD clinical practice guideline, there is a recommendation for sort of community-based interventions around lethal means safety, but not individual ones. That doesn't tell us it doesn't work. We just don't have the really strong research yet in this area, but it is certainly growing. But one study that we do have was a study that was done with the Israeli Defense Force, so also veterans, just not U.S. veterans. I'm sorry, service members. And this was from the early 2000s. They found that 90% of the suicides that were occurring in the IDF were by firearm, and most occurred on weekend leave. So they weren't happening during duty time. They were happening on leave. So what they went ahead and did is implemented a policy where they required soldiers to leave their weapons on the base during weekend leave, so they didn't have access. By doing that alone, the suicide rate decreased by 40%. So not having access made all the difference. They found that the weekend suicides dropped significantly and weekday suicides did not. So this wasn't about some sort of non-specific effect on weekday suicides because they were paying more attention to it or anything like that. It was specifically during the time period where they did not have the access. I think this points to a number of things. One certainly being that access matters. The other piece is that we want to make sure that our interventions are really well informed, and we can be doing simple things like this to help drive down rates, which is really important. Okay, so what do patients and gun owners think about this? There was actually just recently a conference in San Francisco where the head of the National Shooting Sports Foundation was there supporting this conversation about lethal means safety. And I'll talk a little bit more about what we know about those groups in just a moment. But if we think about patients, this was a survey that was done with almost 700 veterans who had received VHA healthcare, and it talked about the acceptability of different firearm interventions. So 93% of the respondents said that they would be open to one or more health system interventions addressing firearm access. So really sort of high approval for that. 75% of them endorsed interventions that substantially limited access. So also endorsing that. Half of veterans with household firearms would personally participate in at least one intervention. And among the respondents with PTSD, 76% endorsed one or more high-intensity intervention. So a lot of sort of acceptability for this among the patients that we're serving. one thing that I think gets in the way of us having these conversations with patients is our own feelings about this, our own discomfort about talking about it, especially if we are not somebody who owns firearms or is sort of part of any firearm culture. These conversations can be uncomfortable. And we may think that the patient is far less interested in having the conversation than they actually might be. So it's certainly worth getting comfortable and giving it a try. So if we go to firearm advocacy organizations in the business community, so on the left here, you see this pamphlet that was put out by AFSP, the American Foundation for Suicide Prevention, along with the National Shooting Sports Foundation together. So that obviously speaks to that collaboration. And then on the right-hand side, this is a sample flyer. Some of you may have heard of the Gun Shop Project. This is a sample flyer that was sent out to gun shops, and it just asked them to post these flyers. There was no real follow-up. They just sent them out. And then folks from the Gun Shop Project went and checked at the places where they were sent, and they had a really impressive rate of firearm business owners who posted these signs, and they're clearly very concerned about safety as well. And so there is this nice partnership happening in many places among these communities, which is really, really great to see. Okay, so that's a lot there in terms of background. I'm going to move a little bit into the who, which is pretty brief, and then we'll move to the what in terms of having these conversations. Some of you may have seen this before. This is referenced in the updated clinical practice guideline for suicide prevention, and is something that was put out by our Rocky Mountain MyRic a while back. In the new comprehensive suicide risk evaluation in VA, if you've seen it before, you know that you're asked to stratify acute and chronic risk in there, and those risk categories map onto this table. The link is on this slide. You can download the table from there, and you can also go to our order form on our MyRic website, and we can send you as many laminated copies of this as you would like. So feel free to request those if you would like them. But what it's showing on here is that when we're talking about acute risk, we're thinking about folks that are identified at intermediate or high acute risk. Those are folks who it would be good to have a conversation about lethal means safety with. Similarly, for chronic risk, folks that are identified at intermediate or acute, or intermediate or high chronic risk, we should have these conversations with. So then I often get the question is, well, what if somebody's at low risk? That certainly doesn't mean you can't have the conversation with folks at low risk if you have other reasons to be concerned. You just want to think about things like, why you're wanting to have the conversation. What are their protective factors? Are they engaged in care? Do they have some ongoing life stressors? So for example, somebody may be at low risk right now, but I know that if certain things happen, their risk could change quickly. And so I might still have the conversation with them, for example. So feel like you certainly could in those other risk categories, but absolutely be considering it for intermediate or high acute or chronic. Okay, so now let's move into the what, and this is what we'll spend the rest of the time really focusing on. Okay, so simply put, in terms of what is lethal means safety counseling, it's working with veterans and their caregivers, friends, or family members to facilitate limiting access to lethal means during high-risk periods. And you see a couple things underlined on here. So one of them is the word facilitate. We are collaboratively doing this with the veterans and their loved ones. We are not doing this to them or for them. This is a collaborative discussion, and we really allow the veteran to have autonomy in this and to do some shared decision making. That's essential. The other piece of this is thinking about doing this during high-risk periods. It's important when we're having these conversations to not make it sound like we are saying that they must lose access, for example, to firearms for the rest of time, where they need to be prescribed limited amounts of their medications for the rest of time. Risk changes a lot over time, and if we are able to work with the veteran in other ways to help mitigate their risk, then we can certainly revisit conversations about access to lethal means and change that picture. So that's important to It's also important to remember that you're already doing a lot of this. This is part of what step 6 is on the safety plan, which I'm sure you all are familiar with, and this is part of making the environment safe. So a lot of those conversations you're already having hopefully can just be enhanced by learning this additional information. This is from one of the sort of safety plan guides that's out there. There's some nice sample language on this. That's why I have it on this slide. I'm not going to read through it all, but there is some nice language on here, kind of examples of how you can start to have the conversation that I felt was helpful and wanted to include for you all. Okay. So when we approach these conversations with patients about having, about thinking about lethal means safety, this is a really patient-centered and collaborative approach. We can't give you sort of the end-all, be-all, what's going to work for everybody, just like we can't with a lot of things related to mental health treatment. This is not a one-size-fits-all type of a thing. You're really going to be working collaboratively with the veteran to make a plan that makes sense for them and that they're going to actually be willing to implement. So doing this in an effective way, we also need to really consider language. I think it's critical to consider culture around firearm ownership. So if you have the time in the relationship there, I think it's incredibly important to get a good understanding of what the firearm means to the veteran. So asking questions about if they were sort of raised with firearms, if they've been exposed to them their whole lives, or if this is new since the military, and why do they have a firearm? What value does it serve for them? If we're going to be talking about potentially keeping them away from something they really value, we need to understand that. And so having those conversations is a really respectful way to go about that. This also isn't a one-time conversation. It involves follow-up. So you're going to make some initial plans, and then you want to follow up on those plans. You know, we do, as I mentioned earlier, we still have a lot to learn as a field about effective lethal means safety counseling for veterans. But what I'll share with you today are just some suggestions based on what we do know thus far. Okay, so some of these factors that can impact how the conversation goes that are on this slide, I've already mentioned some. So certainly your relationship with the veteran. If you're having this conversation with somebody, for example, in the emergency department, and it's the first time you've ever met this patient, that might be a different conversation than with your ongoing psychotherapy patient you're seeing weekly, right? It certainly could shape things. Your knowledge about their access to firearms or other methods, and certainly their knowledge of and comfort with firearms or other means is going to matter. So again, really getting a good understanding of what these means mean to the individual is incredibly important. The urgency of the situation will matter, right? So let's say it is the emergency department and you're deciding whether or not you're going to admit somebody or have them return home. Having that conversation about lethal means safety might be a big crux of that decision making, right? So they have a loaded, unlocked firearm at home. If they are unwilling to do anything to change that situation, that might be thinking, might lead you to think of their acute risk being a bit higher than if they were willing to partner with a family member to secure the firearm, at least during this stressful time, for example. So all of that's certainly going to matter. You want to, just as in any sort of shared decision-making conversation, you want to be checking out the feasibility of the plan, seeing if it seems like they'll actually follow through on the plan, are they comfortable with the plan, so on and so forth. So one thing to keep in mind is that language really does matter when we're having this conversation. So this was a study that was done with some undergraduates, may or may not have been veterans, certainly wasn't specifically. So it's a little, you know, a specific sample here, but it was interesting and I think worth noting. So they were asked about firearm safety in a hypothetical clinical encounter, and they were asked about acceptability and intention to follow recommendations based on these two little vignettes. So for the first one, they imagined that the provider was saying to them, my goal is to keep you alive and to protect you from hurting yourself or others. Because I'm concerned about your well-being, I want to have a conversation about means safety. And then on this next slide, you see for group 2, everything was the same, except that instead of saying means safety, they said means restriction. And what they found was that when they used the word safety as opposed to restriction, the folks in this study found that to be more preferable, and they said they were more likely to follow through the recommendations. So I think over time, folks are talking about means safety much more commonly than means restriction. We still hear means restriction very often, but that's why you'll hear me always try to say means safety. I'm sure I mess it up sometimes, but to say means safety as much as we can, and certainly to be talking to our patients about that instead of restriction, because that certainly can sound very aversive and doesn't reflect really the collaborative nature of this. Okay, so here's an example, just a couple quotes here I'll read through of sort of how you could bring this up with a veteran. So lots of veterans have guns at home. What some veterans in your situation have done is store their guns away from the home until they're feeling better, or lock them and ask someone they trust to hold on to the keys. If you have guns at home, I'm wondering if you've thought about a strategy like that. So it's a way to just sort of ease into it. It's normalizing what this might look like. It's talking about what other veterans have done in the past and seeing what they're comfortable with. And based on how they respond, then you can kind of go from there and see what they're willing to do. Go through different options. And you could follow it up depending on their response by saying, if temporarily storing them elsewhere is not an option, perhaps we can discuss some alternative ways to keep you safe. And so these are just some examples of how to talk through this. In these conversations, you want to pull from your good skills related to motivational interviewing, certainly. You want to be evoking some change talk. You want to be doing this very collaboratively. I apparently can't say that enough. And really, really respecting autonomy of the veteran. And that this is not our call to make, it is theirs, and we are just there to sort of counsel them through it, provide them with information and recommendations, and at the end of the day, they get to choose. All right, so I'm going to focus for a little bit specifically on firearms again, and talk through some options for safe storage. So temporary off-site storage is certainly the safest thing we can do. So if they don't have ready access in their home, that's going to be the safest thing. This slide talks through some options that you could propose to a veteran and put sort of problem solve around or brainstorm around. These different options, you're going to want to look into what is feasible in the area in which you live. So for example, some pawn shops will accept firearms and store them for somebody for a small fee. Some police departments will just take them at no charge, particularly if they know the person's a veteran. And some gun stores will as well. So it can be helpful to maybe partner with your suicide prevention team at your facility to see if they already know the answers to these questions. And if not, maybe as a team, you all can find some of this information out to see what the options are. Because as we all know, not all of the veterans we serve have family members or friends that they give firearms to. And again, this is temporary. So some other options. When you're thinking of other options, so if they're unwilling to have the firearm outside of the home, you want to be thinking about things that are going to create time and distance between that urge to kill themselves and the firearm, right? That's going to reduce risk. So time and distance. So following that, a locked gun poses lower risk than an unlocked gun, and an unloaded gun poses lower risk than a loaded gun. So you want to be thinking about if it's unlocked and loaded, and then if they're willing to change either of those circumstances. So they could store the gun unloaded, they could store the ammunition separate from the firearm, they could store the ammunition actually locked up, but the gun out, all sorts of different combinations. And as different as each one of us are, these plans are going to be different as well. Everybody has different preferences. I worked with a veteran once who was unwilling to hand over his keys to his gun lock. He did have it locked, but he was unwilling to give the keys to anybody else, including his wife, because he wanted to be able to access it for safety reasons if he wanted to and didn't want an extra step. But he knew that he was going through a rough time and needed to keep himself safe. So he came back in with the idea that he would freeze the key to his gun lock in a block of ice, keep it in the freezer. He could quickly get it if he wanted to, submerge it in hot water, do different things to kind of melt away the ice. But it did create an extra barrier, so time and distance, right? So it was a great solution. He came up with it, and he executed that himself. Okay, so these are different locking options if you're unfamiliar. I'm going to go from the top left across and then down. So a cable lock, a trigger lock, a lock box, a life jacket, and then a gun safe or cabinet. These may look different depending on the product, but just want you to see a visual of them. If you're unfamiliar, there's a lot of different ways to lock a firearm. And so different veterans are comfortable with different options. And so you'll, again, just want to work with the veteran you're serving to see what they're comfortable with. The VA does offer free firearm cable locks, that first one there with the red kind of cable on it. And so we can offer that for free, but some veterans are not comfortable with that and they prefer a different type of lock. So again, it's just having the conversation and seeing what they are wanting to do if they are wanting to lock up their firearm. So some other just options here. We already talked about kind of giving the lock away to somebody else, asking somebody else to change the safe combination. So maybe they store them in a safe with a combo lock. They have somebody change it so they don't know what it is. But again, they could get it in the future and potentially disassemble the gun. They could remove the firing pin, give that to somebody else. Again, essentially make the firearm. But then they still have it in the home and didn't have to hand it over to someone else, which can just feel better to someone else. Okay, there's going to be barriers that come up, right? These conversations aren't going to necessarily always be perfectly smooth. I think if you are collaborative and you are transparent, that's going to help a lot. And you're not trying to control the conversation too much, it's going to help a lot, but things are going to come up. And that's okay. You just have to be really open to problem solving around this. Folks might talk about, concerns they have about personal and household protection. So you want to work with that. If you're working with somebody, for example, in treatment related, CBT type treatment, you can explore their cognitions about that. Sometimes there are not family and friends to really involve in this plan. So that could be a barrier. And then again, going back to this idea of what does it mean to give something up that you enjoy and value, and having conversations around that and thinking of ways that they might be able to fill that need in. So as I was saying earlier, there's this idea that, some ways of locking firearms or securing firearms might be more safe than others, and everybody's going to be different. So just like people have different preferences around Pepsi or Coke, people have different preferences around firearm safety. So this goes through some research that was done by a colleague of ours here in the MIREC, Joe Simonetti, with a survey he did, and found that there was, big variation in terms of the types of locks folks want to use. In the study he did, he found that only 12% would use a cable lock. So that doesn't mean that we still shouldn't offer it. We absolutely should, especially because it's free. But we need to be having these conversations. And remarkably, in terms of the value piece, he found that 90% of the folks he interviewed said that it was very important or absolutely essential to be able to unlock the device. So folks are often willing to have this conversation, willing to take steps to make, to secure their firearm, but still want to have control over the situation, understandably so. Okay, so now we're going to step away from firearms again for a moment and move to medications. So there's some sort of decision tree, decision tree that we can use to kind of guide our conversations around medications and lethal means safety. So think about if the medication is potentially toxic, and also think about if it's essential or non-essential. So when we're talking about essential or non-essential, an example of a non-essential medication might be acetaminophen that they take for the rare headache. Okay? That's not essential. Whereas if they're on a mood stabilizer for bipolar disorder, let's say lithium, which might be highly toxic, but they really need it, you might be having a different conversation. So let's dive into that a little bit more. If we're talking about the essential medications, so ones that they really do need, Some considerations are blister packets for home medication. So that's what that picture is of there. It obviously, if somebody was feeling suicidal, it would take them a lot more time and effort to pop out each one of those pills individually than it would be for them to take an entire bottle of medication, right? Time and distance. So if your pharmacy is willing to provide blister packs, some are, some are not, that is a great route to go and a good recommendation. They could secure their medication. So I've had many conversations with veterans about using pill boxes where they only put out a few days of pills at a time and then secure the larger bottle of them in the cabinet. Sometimes people have used the cable locks for firearms to actually secure their cabinets for the medications as well. A lot of creative solutions. So that's one thing they could do. Also, they could talk to their prescriber about reducing quantities. So many of you have probably seen that sometimes when folks get discharged from an inpatient psychiatric hospitalization, for example, they only get a week at a time of medications, and that is a safety sort of precaution. Another important point is when we're thinking about this, to not just think about their medications, but others in their household and what they are prescribed, or old medications that they have in the home. You would use similar strategies if they were essential medications, but really recommend thinking about that as well. Okay, so if we're talking about non-essential medications, there's a few options here as well. So medication disposal kits are available. There's these mailers that folks can get to mail in their old medications. Many VAs now, so I think it's over 100 now, so most VAs have these MedSafe bins where you can just dispose of your unwanted medications, and there's guidance sort of on the bins for how that goes. At our facility, they're right outside of the police station, and so that's certainly something to look into. If your facility does not have those, I have the contact information for who to contact to look into getting those, so feel free to reach out if you need that. We have trash on here with a question mark. Certainly it is not recommended that pills get flushed down the toilet or put in the trash because they can get into water supply systems. People can get them from the trash, things like that. It is not the safest method. That being said, if those are the only options and it's somebody you're really worried about, we obviously are going to prioritize getting those medications out of that person's hands. And so it is an option, but that's why the question mark is there. Okay, so then if we speak for a little bit specifically about opioids, suicide risk certainly is increased with folks who have access to opioids, whether they're prescribed or not. Unintentional overdose is another risk. I was mentioning storm earlier, and is a risk when folks have access to opioids. So there's a couple different options here. You can get some training about this. The link is here on naloxone. But essentially, if somebody's prescribed an opioid, you're worried about their risk at all, getting them access to a naloxone kit can certainly be a life-saving intervention. Okay, so when you have these conversations, even if the veteran declines to have the conversation or isn't sort of landing on the solution that you proposed, folks have asked if they should document this, how they should document it, so on and so forth. So I have a few documentation examples on here, which I'm not going to read fully through. But what you'll see in these is that there's often a reference to sort of checking back in with the veteran in the second one, checking back in with the veteran to see if they actually followed through with the plan as expected. And the plans differ a little bit depending on the level of risk as well. So they're going to really vary depending on all the factors that we've talked about. But there's a couple documentation examples there where you see the reference to the risk level and then the plan that was agreed on. Okay. So a few considerations here for lethal mean safety with veterans with PTSD. I tried to sort of make this quote shorter, but I really like it, so I'm just going to read it. So this is from an article about veterans with PTSD. So given the possible reluctance among many veterans with PTSD to entrust their firearms to friends or loved ones before an alleviation of their PTSD symptomatology via treatment, clinicians might first focus on safe storage practices and not take the risk of damaging the rapport by immediately challenging this possible avoidance strategy. Kind of a mouthful. But what it means is when we're first starting out with somebody, and for those of you who treat folks with PTSD, I'm sure you've experienced this. Certainly that trust comes up a lot, and it might not feel quite right to have a conversation during your first session, for example, about giving their guns away. You just get the vibe that that is not going to go over well. That's okay. That doesn't mean you still can't talk about lethal safety. You just might start by proposing sort of a lower level intervention, like safe storage in the home, and kind of go from there. So it's really important to just be respectful of that experience of the veteran, push them as you feel appropriate to do, but of course to keep that collaborative. Then there's a couple tips on here specific to PE and CPT if you happen to be working within those interventions. This slide has some additional sort of conversation points. So talking about how you currently store firearms or medications. Can you think of anything that you would do to increase your safety? What concerns do you have about taking these extra steps? What can you do to help keep yourself safe? Just again, different sort of wording for how to talk about this. Here's some examples related to stuck points and some ideas that folks might have and kind of respond to you with. So one is, if I get rid of my guns, I'll just use another method to kill myself. That's sort of something that somebody might say, or something that you might be thinking is true. And in fact, research suggests that people do not often substitute their methods. Typically, if we remove one method, they don't replace it with another. But even if they did, if the starting point is firearms, any other method is less lethal, right? So even if they did then try to overdose, it is far less likely that's going to result in their death than if we had done nothing about their firearms. So it is still worth reducing access to firearms if they're willing. I need my guns for self-defense. This is one certainly commonly hear. In that case, we would recommend working with the veteran to really weigh the risks of owning the firearm and any potential benefits of the rare case that they might need to use it to defend themselves. So you can kind of do the whole which is more likely kind of thing, where is it more likely that you might harm yourself or your children might find the firearm, as opposed to you're going to get broken into and you need to use your firearm. Which of those is more likely? Because having the firearm solely for that reason is really attending to the rare case that they may need to defend themselves. And again, if we're talking about a temporary amount of time, we're just talking about how high is the risk of you potentially harming yourself or somebody else right now. I've talked to veterans before about, hey, you told me that when you get startled in the middle of the night, the first thing you do is go grab your firearm that's on the bedside table. Well, what if, and sometimes you wake up in the middle of a nightmare and you're basically still feeling like you're in the nightmare. So what if that happens and it's when your fiance walks in? That's pretty dangerous. And that kind of scenario, you can use your CPT skills and talk to them about, how many times a week do you have those nightmares and the circumstance happens versus how many times a week does your home get broken? And you can kind of work from there. Okay, so this is a case example. I'm aware of the time, so I'm going to go through this pretty quick, but I think it's a nice example of kind of how this can change over the course of treatment with someone. So this was a pretty young veteran that was served here at our facility, and he had PTSD due to military combat trauma. He felt really responsible for another soldier's death and had chronic thoughts of suicide with the plan. Hanging, no intent, no past attempt. He had access to a loaded firearm at all times, this person or at his bedside, and said this is the only way it is. And so during intake, he was unwilling to have any conversations around safety whatsoever. So the provider certainly respected that, but kept it in mind to continue to sort of assess and see if there was anything there. During the course of treatment, the veteran was able to identify a bunch of trauma-related beliefs that did end up sort of being related to the firearm issue. So if something bad happens again and somebody else dies, I can myself. And so felt from there that he was responsible for everybody's safety. Somebody's going to break into my home. My fiance is going to die. I won't ever forget what happened to my buddy who died. So all of these sort of beliefs that are related to his firearm ownership. Over the course of treatment, his cognition started to shift, and he was able to start sort of weighing the likelihood, like I discussed earlier. And also in this process, he realized how much he really did not want to die, and that sort of awareness and new value allowed him to commit to safety and doing what he had to do for safety, even if he was uncomfortable with it. So in the following bullet points there, you can see that over time, sort of he was willing to do more to stay safe. And the therapist just sort of, stayed connected to him and respectful of what he was willing to do, but did also keep bringing it up again, and it changed over time. Okay, so in summary, facilitating lethal means safety among our patients that are identified to be at risk is considered an essential evidence-based component of effective suicide prevention. We know that our patients who are veterans are at increased risk for suicide, especially firearm death, but other deaths as well. We're going to use our risk stratification to identify those who should receive lethal means safety counseling. You have different factors you want to consider in these conversations. And it's important to remember that home runs are rare with behavior change. This stuff doesn't happen overnight, just like with that. So incremental changes are possible, time and distance. These are some specifics of PTSD, which I just went over. One resource I want to make sure you all know about before I close is the Suicide Risk Management Consultation Program. So this is a service that we have in VA where anybody who serves veterans, whether they're in VA or in the community, does not have to be a VA employee, can consult with us. This could be on a case where they're concerned about somebody's risk and they're not quite sure what to do, or they just want to run things by us, or they have questions about suicide risk management, which may or may not be related to lethal means safety. Any of that, you can feel free to consult with us. I recommend you check out our website just to learn more if you have any questions about the presentation today or that service in particular.
And such great concrete examples of how to talk with patients about lethal means safety. So I did put down in the chat box that if people have any questions, please feel free to start typing them in, and we'll give you a minute to type them in there. It's pretty quiet. So we'll give you another minute. I have to say, your example of someone freezing the keys to their gun lock was like an example, I think, of how creative we could get with this. So I thought that was really great. So thank you for that. I see a couple people.
Yeah, thank you. One thing I wanted to add that I didn't mention is that when I started doing a lot more work around lethal means safety, I sort of had this imposter syndrome because I did not grow up with firearms. I had never been around a firearm, and now I'm talking to veterans about firearms and safety and something that they clearly know. So I don't think this is necessarily for everybody, but there was a group of us here at the MIREC who were feeling the same way, and we were able to coordinate with one of our local gun shops to go and actually take a course that they do with new firearm owners, where we just got to learn like the ins and outs of firearms. We got to handle firearms, take apart firearms, put them back together, and that helped my comfort level and just sort of confidence in having the conversation immensely. And so just wanted to share that also, that doing things like that to increase your own discomfort is really helpful. And make those conversations go more smoothly. Yeah, so assume that these principles would also apply to public safety or police officers. Absolutely. I mean, I think that this really would apply across the board for anybody who's having these conversations, especially with all the caveats that how these conversations go are going to depend on the context and the relationship. So there's no one size fit all, and there wouldn't be in that context as well. So I think in particular, if it's a police officer or safety officer, the thing that I would really want those folks to be stressing is that they're not trying to take away their guns. I mean, veterans can think that enough with us as mental health providers, let alone with the police. So clearing up confusion around that, and I think would help alleviate probably a lot of anxiety on the veterans' part in having those conversations with law enforcement. But I think they could be critical partners in this
I think
effort.
there was a
Certainly.
question actually about whether this presentation, which has been really excellent, which is part of the comments there as well, will be available. We did record this presentation, so it will be available on the Division 18. A link will be available on the Division 18 website within a week if anyone missed a part of it. And I did also want to mention that if anyone would like to receive a CE credit, I will be sending out an email shortly with a link to the questions that would need to be answered to receive the CE credit. If you are a member of Division 18, this is a free CE credit. If you are not, on the email there will also be a link to PayPal for $15 for the CE credit. If there are no other questions, I think we can wrap up. Thank you again so much, Dr. Matarazzo. This was really, really great. And I really appreciate you taking the time and speaking with us through Division 18 VA section here. And I want to thank you all for attending. And we'll be in touch soon about future webinars through the VA section. So thank you very much.
Thank you all so much. Thanks for the opportunity, and thank you for attending.